May I ask the speakers to come on the stage, please? Dr. Osama, Dr. Iftikhar. And while you are here, before the questions start, I need to share a case about I did a surgery, MGB of course. So during his surgery, the first 45 mm stapler that got misfired, so I had to use another 45 mm. Anyway, the surgery went well. That young lad came after a month or so, and he had intractable vomiting. Abdomen was soft, heart rate was like 70, nothing wrong, but the vomiting was not stopping. And we did, I looked at the video, reviewed it. Maybe I have transected the stomach so that there is a gastroparesis or there is other issues. But he didn't tell anything. So when he was going for endoscopy, he told the gastroenterologist, please don't tell my surgeon. I'm from UK, I can't get free access to cannabis, and I am just having this pot as much as I can because I'm flying back to UK in a week's time. So there's a hyperemesis syndrome with cannabis, although cannabis is also as a medicine used for treating of vomiting as well. But when you smoke, then it's a different thing. So your presentation reminded me of that, and how his family was aggressive and they thought I have done something. And I shared his video on social media, and almost every surgeon said you have didn't left any drainage from the remnant stomach. So this was a difficult case of me, but hopefully it was done. So any questions from the audience regarding these presentations?
All right, so my question is with Dr. Sama. Dr. Sama, you said that we can leave minimal type 1 paraesophageal hernia alone. What does that term mean? Secondly, if you are typing it on the basis of size, how do we measure it intraoperatively? And is this approach applicable to both the procedure like sleeve or bypass?
So minimal type 1 is not a paraesophageal hernia. Any paraesophageal hernia is at least type 2 and it has to be treated. So type 1 only if there is actual migration of the gastroesophageal junction. So once you reflect the fat pad, then you reassess if you can see any part of the esophagus below the diaphragm. If you can see any part of the esophagus below the diaphragm and there is not a large defect, then you don't need to do anything about it.
That's exactly what I'm asking.
Yes.
How do you define a large defect and a small defect?
So there is no agreed upon definition of large versus small defect. However, some of the studies recommend 2 centimeter, other recommend 3 centimeter, less than 3 centimeter. But 3 centimeter to me is quite big. So less than 2 maybe. But the main thing is whether there is a migration of the gastroesophageal junction. And the other thing is that because there can be some anterior dimpling, but once you remove that fat, then that's gone. But if there is a persistent defect, you can see a defect in the hiatus anteriorly, then that needs a formal dissection.
So we are strictly talking about sliding hiatal hernias?
Yes, because all type 2, type 4 will need a repair.
Sure.
So sliding only if there is a visible defect after removal of the fat pad, after reflection of the fat pad, or there is actual migration of the gastroesophageal junction.
And you'll still repair it posteriorly? So
Yes,
you're not,
always.
Not
always.
stitching interiorly? Right?
Proper dissection, because after proper dissection, you have to do 360 mobilization as well as high dissection into the mediastinum and then repair it posteriorly.
Thank you so much.
Anterior only if there is speed bumping.
Can I ask a second question with Dr. Iftikhar? Sir, you said that multidisciplinary team approach is very important while deciding concomitant repairs of ventral wall hernias and bariatric surgery. What should be the composition of that MDT team?
Yes, so we have anesthetist, we have surgeon, we have dietitian, especially a psychologist. This is our multidisciplinary team in this. And if you have a special hernia specialist, must add in it.
So is there a role of a plastic surgeon in it?
Sorry?
Can a plastic surgeon help?
Yes, if there is a issue of domain, then plastic surgeon can be added in it.
Thank you.
So one clarification, like Dr. Atif, Dr. Javed, if you can. Often I have heard like if the defect is less than 2 centimeters, just leave it alone in hiatus. Is this defect a true term, or is it just arbitrary? Is it before the dissection, after the dissection? Is it the depth or the width of the hiatus? What is your take about this?
So, thank you. I think it's a very important point when we're doing sleeve, for example, and you find a dimple, leave it alone. If it's a dimple, leave it alone. If you are going to dissect the hiatus, you cannot do halfway, because then you predispose them to development of a hernia, you're disturbing the anatomy. So you either leave it alone, or you go, as Osama said, do the posterior hiatal dissection, take the esophagus out of the chest, and repair it. So halfway, okay, maybe there's a hernia, maybe there's, you can dissect the fat pad, but do not touch any ligaments or any structures which are holding. So that's the clear message I want to give. I'll stop. I think we'll carry on.
Thank you. And second question is with Abril and Matt. Now here, because of the social media in Pakistan, bariatric surgery is getting more and more in children and adolescents. What's there in UAE, in Taiwan? Do you offer bariatric surgery? If yes, which procedure do you prefer, bypass or sleeve?
So, again, that's a very good question that I think is going to change in the future. So think about that, they're talking about obesity as a chronic disease, which we can discuss that. Think about that, we're saying that a child of 13, 14 years old is going to have chronic, and is having a chronic disease. So those ones are the ones that potentially the obesity is going to recur because they're the youngest. You have that child, so what surgery are you going to offer to that patient? I think everything is going to change with the GLP. I was going to ask Dr. about the GLP. I think GLP, we cannot be against that. It's a medication that works, and I think that medication should be the first treatment for kids. I really don't know how safe, or if there's any paper, any work about the safety concerns with kids. But I think it's the best tool that we should use would be a GLP for kids. But if you're planning to do any surgery, try to do the less aggressive thing, which is the sleeve gastrectomy. I don't think bypass is option. It's a bit, you have to have a real reason to offer a 14, 15, 16-year-old child a gastric bypass. Even I can tell you, even a sleeve plus, I don't think it's reasonable. I think we should work harder with these kids to try to avoid any surgery. But if we cannot do anything else, surgery should be available for them.
I think the same opinion from Carlos. If right now in Pakistan you want to do a surgery for the adolescent, my opinion right now use sleeve and plus GLP, do a replacement, because somehow the small bowel intervention, the result, the metabolic effect could be achieved by the GLP right now. So we could offer you some space to negotiate to prevent any unnecessary complication in the future. But nowadays in Taiwan, the something we do for the sleeve plus surgery is several kinds. The most we do is small bowel shortening. I think something good for this part, you did not take a small bowel away, like a bypass. You did not take any organs away. So you could remain some space to turn it back in the future. But whatever, you must understand the good part, the bad part in the procedure you offer for your patient. Reserve some space for their future. I think the things I want to recommend for all audience.
Thank you.
You have your phone, your microphone there.
Actually, we operated 2 patients. One of our patient in the family, the child died because of the obesity. The child had comorbidities, He was around 14 years of age. We defer them for the surgery. The patient was sent for the GLP-1s. The patient was put on GLP, but he was not improving. There was no any weight reduction in patient with the GLP-1 in that boy. So, due to the severity of the comorbidities, the family lost the child. The second child, who was 13 years of age, who again came back, and they said that we are going to take the risk this time, and we did a sleeve gastrectomy on that patient. So the patient improved very well, and the patient we operated like almost 2 years ago on that patient, and that boy is doing really well. The patient is on follow-up with us. The good weight reduction has been observed, and the normal lifestyle has been achieved. So the cases is, we do not have the long-term data available. We just operated only 2 patients in past 5 years. And again, the reasons were because of they lost 1 to 2 child in the family because of the obesity. That is why they were able to take the risk for any kind that they could save the child. So this was one of the indications that we operated on, but we do not have any particular data available whether to go for a surgery in that younger patient, because both the 2 children were 13 years of age. So this was our experience, but we'll see that in the future, because GLP is improving very well. In the past 2 years, 2 years ago, the GLP-1s were not very commonly. They were there, the semaglutide was there, but it was not very commonly used in patients, especially in the children. So this could be, this was our experience.
So I have a question for Madhya. Do you counsel the husband about that shopping addiction, which can happen after bariatric surgery?
When the counterpartner is available, we do tell them, especially in the female patients. We have come across this problem in the female patients, that they may have a strong shopping addiction afterwards because they need something to, put the depression on. Thank you.
Do they change their decision then?
Thank you very
They
much.
have to choose either of it.
Thank you very much for all the speakers. Congratulations, nice talks. And I think we should go in applause, and we should go for the next session.